Assalamu alaikum. This is Dr. Mariam Al-Abdallah, professor in orthodontics at the University of Jordan and a senior orthodontic consultant at the Jordan University Hospital. This is our second lecture on the development of normal occlusion. Just to remind you of our reference, it's chapter 4 from Handbook of Orthodontics, Copern and DBA's second edition. And we already finished up to the eruption of the permanent teeth. So we're going to continue from here, eruption of the permanent teeth. We talked about the eruption of the permanent teeth that is the start of the mixed dentition. And we said that the eruption will have two stages, the pre-emergent eruption and the post-emergent eruption. We also talked about general rules of eruption of the permanent teeth, where females precede males of about 5 months. The mandibular teeth precede the maxillary ones. And once the crown calcification is completed, then the permanent tooth will start eruption. And the pre-emergent eruption will take about 2 to 5 years to reach the alveolar crest. And then we have the post-eruption spurt, will take about 1 to 2 years until the tooth reaches the occlusion. When 3/4 of the root formation is completed, usually we will have the tooth will emerge inside the oral cavity. And after that, after eruption, the root will take about 2 to 3 years to be fully calcified, to be fully formed. Now, in terms of sequence of eruption, the permanent teeth erupts in groups. And we have 3 important phases. The first phase is eruption of first permanent molars and incisors. The second phase is eruption of the premolars, canines, and second molar. And then the third phase, eruption of third molars. Now we're going to talk about eruption sequence in terms of dental age. So at dental age 6, the teeth that will erupt are the lower central incisors. So you can see this diagram where we have the white teeth are deciduous teeth and the pink teeth are the permanent teeth. So we have the lower central incisors erupting, closely followed by the lower 6th and then the upper 6th. So this, if your patient looks like that, then this is a dental age of 6. So these are the lower central incisors, permanent. And this is a little bit beyond 6 years of age because we have exfoliated upper deciduous central. But this is the difference in terms of anatomy, color of the incisors, of the permanent incisor in relation to the deciduous incisors. At dental age 7, we will have eruption of the maxillary central incisors and the mandibular lateral incisors. Root formation of the maxillary lateral incisor is well advanced, but the maxillary lateral is not erupted yet. Canines and premolars are at the stage of crown completion or at the start of root formation. At dental age 8, we will have eruption of the maxillary lateral incisors. So as you can see here, all incisors now erupted. The last one is the maxillary lateral incisor, and the rest of the teeth are continuing with the root formation. So this stage is followed by 2 to 3 years, no eruption. So after dental age 8, we will have 2 to 3 years of no eruption of any further permanent teeth. Of course, this is on average. At dental age 9, we will still have the same, of course, centrals erupted and laterals and the permanent first molar. But what happens inside the bone is that about 1/3 of the roots of the mandibular canine and first premolar is completed, while the maxillary canine, first and second premolars, and the mandibular second premolar root development is just starting. So this is around 9 years of age. You can see that these are the permanent teeth erupted. And we have the CDE in the maxilla and the mandible are still there. There is root resorption and of the deciduous teeth, of course, and root formation of the permanent teeth that is progressing. At dental age 10, there will be approximately half of the roots of the mandibular canine and first premolar have been completed, and nearly half root of the maxillary first premolar is completed, while we will have a significant root development of the mandibular second premolar and maxillary canine and maxillary second premolar. At dental age 11, we will have actual eruption of the mandibular canine the mandibular first premolar, and the maxillary first premolar. So the white teeth now are the only deciduous teeth left to be replaced. So we have the maxillary C, and the maxillary and the mandibular E's are still inside the oral cavity. This is dental age 11. At dental age 12, we will have the eruption of the second premolar and the maxillary second premolar and canine. The second molars, the second permanent molars, are nearing eruption, just about. So this is age 12, where we have all permanent teeth erupted, and the second permanent molars are about to erupt, while we have advanced development of the follicle of the third wisdoms. Dental ages 13, 14, 15, we will have completion of the roots of the permanent teeth and full eruption of the second permanent molar. If the third molar is going to be formed, it should appear on the radiograph by the age of 15. After that, we can consider it congenitally missing. So this is age 15, and this is 21, where we have a fully erupting permanent third molar. So this is progressing from the fully functioning primary dentition all the way to mixed dentition, and then we have the fully functioning permanent dentition. So as we said, a change in the sequence of eruption is much more important as a sign of disturbance than the actual timing of eruption. Okay, so if, for example, a central incisor erupts, we expect the contralateral to follow it by about 6 months up to 9 months. This is considered normal. If it doesn't erupt, then there is a problem. So not only the sequence, but also the symmetry of eruption. Okay. And of course, early stages of mixed dentition, we expect some temporary open bite, because we will lose deciduous tooth, and then the permanent tooth will take some time to erupt. So we will have normal physiological open bite, temporary open bite. Now, in terms of the mesodistal size difference between the permanent incisors and the deciduous incisors, the permanent incisors are larger, are wider. The difference between the mesodistal width of the upper incisors relevant to the deciduous incisors is, as we said, in the maxilla 7 millimeters, while in the mandible it's about 5 millimeters. This difference is called incisors liability. Incisors liability. So, how can we solve this problem, the difference between the mesodistal width of the permanent and the deciduous incisors? Because if we don't have extra space, we will end up with crowding. Now, the permanent incisors tooth pods usually lies lingual and apical to the primary incisors, both in the maxilla and in the mandible. So if there is, when they usually erupt, they erupt a little bit lingually, and then they will normalize in position and move labially. If there is any little bit of crowding, they will be locked lingually. In the upper arch, usually the lateral will be locked palatally. Okay, but if there is enough space, there will be normalization of their position by the function of the tongue, and they will be pushed labially. So, for example, in here we have a little bit of crowding, so they are locked lingually. The dentist should follow up this patient and extract the deciduous incisors, central incisors, and make sure that these centrals will move labially into their normal position. So in the mandible, mild crowding between 8 and 9 years of age is considered normal because of the incisors liability. So where do we get the extra space to get a normally aligned lower incisors to have a normal development of the occlusion in that area? Well, we will have transverse increase across the canines. The intercanine width will increase, as we said, at that stage in the mandible, about 2 millimeters, in the maxilla, about 4 millimeters. In addition, the incisors will erupt into a more labial position than the deciduous teeth, and that will mean only that we will have a larger arch. And we will also have a distal shift of the permanent canines in the lower arch. Then we will have a distal shift into the primate spaces, because the primate spaces, as you can see with the red arrows, are located distally to the canines. So all these factors should resolve the problem of the temporary crowding within the lower labial segment. Now, in the maxillary teeth, if there is any crowding, any tendency of crowding, what happens is that the lateral incisors will be locked palatally. But if there is enough space, they will normalize in position and they will be pushed labially into their normal line of the arch. Now, the maxillary canine between the ages of 8 till 10 years of ages should be palpated buccally against the roots of the lateral incisors, all the way at the root apex, actually, very, very high up in the buccal sulcus. So between 8 and 10 years of age, it's important to examine the bulging of the erupting and developing canine. If after 10 years of age you don't see a bulge, or if there is asymmetric bulge, one side there is bulging and the other side no, then there is a problem. You need to request further investigation. As the canine develops and tries to erupt, it will push against the distal surface of the roots of the lateral incisors. This little bush will cause the teeth to flare mesially, and this will cause what we call the ugly duckling stage. So the upper incisors normally should be spaced. A diastema of 2 millimeters is considered normal. Nothing alarming, this is considered normal. So if you have parents who are very concerned with the spaced upper labial segment before the eruption of the canine, you just need to reassure them that this is a normal physiological development stage. This is what we call the ugly duckling stage. As you can see, the developing of the canine as it erupts and moves vertically to the occlusal direction. What happens is that it pushes against the distal surface of the roots of the laterals. What happens to the incisors is that they will flare mesially. So this is considered normal. No treatment is necessary to close such diastema in that mixed dentition stage. Now, what about the molar relationship? We said that the normal molar relationship in the permanent dentition, according to Andrews 6 keys to normal occlusion, is class 1. And deviation from this is when the mesobuccal cusp is not occluding on the buccal groove, but anterior to it or mesial to it, then we call this class 2. And if it's occluding posterior to this position, then this is class 3. So how come we move from a flush terminal primary molar relationship to class 1 permanent molar relationship? There are different factors that should play a role to resolve this problem, because if everything freezes and the permanent first molar is guided by the distal surface of the second primary molar only, without excluding the other factors, what happens is that the permanent molars will erupt into a half-unit class 2 molar relationship, and this is not the normal occlusal development. So how do we move from a flush terminal primary molar relationship into a class 1 permanent molars relationship? As we said, there are 3 important factors. We have the early mesial shift, we have the late mesial shift, and we have the mandibular growth that will contribute to resolving this problem. The early mesial shift is where we use the primate spaces. And because the primate spaces in the lower arch is closer to the buccal segment compared to the upper arch. You can see the primate space here is distal to the C, while in the upper it's mesial to the C. So we will have more use of the primate space in the mandible than we have in the maxilla. So we will have an early mesial shift in the mandible more than the early mesial shift of the maxilla. So this can contribute partly to the mesial shift of the permanent molar to contribute to the correction of the molar relationship. The late mesial shift comes from what we call leeway space. Leeway space is the difference in the mesiodistal width between the larger C, D, E compared to the mesiodistal width of the smaller 3, 4, 5. So as they measured the mesodistal width of these teeth, they found that the difference in the lower is about 2.5 millimeters on each side. So we will have extra space as the D, C, E are replaced with the 3, 4, 5. In the maxilla, we will have 1.5 millimeter extra space on each side. So as you can see, the leeway space in the lower is bigger than that in the upper. So we will have relatively a more late mesial shift in the mandible compared with that in the maxilla, and that will contribute further to the correction of the molar relationship. In addition, we talked about cephalocaudal gradient of growth, where the mandible will grow further and more than the maxilla. That means the whole mandible with all the teeth, with all its teeth, will move forward. And again, this will contribute to the correction of the molar relationship. So to sum up, this is the normal, this is the primary relationship, the primary molar relationship, this is the permanent molar relationship. So in the primary, we said the flush terminal is normal. So as you can see, the red line represents minimal growth differential, but the black line represents the normal forward growth of the mandible. The dashed line represents shift of teeth, and this includes the early mesial shift using the primate spaces and the late mesial shift using the leeway space. Okay, so if we have a dark black line representing normal mandibular growth, in addition to the shift of teeth, that's the dashed line, then we should move smoothly from flush terminal plane of ease into a class 1 molar relationship. But if we have minimal mandibular growth, then we might end up with end-to-end relationship, which is half unit class 2 molar relationship, which is not the normal. If we started with a distal step of the E relationship, then we might end up with a class 2. If we're lucky and have good mandibular growth, we might end up with a half unit class 2 instead of full unit class 2. Mesial step molar relationship, again, we might end up with a class 1 if the patient had minimal mandibular growth. But if the patient had normal mandibular growth, then we might end up with a full unit class 3 molar relationship. Again, this is another diagram to show you how a flush terminal can move from the primary dentition to the permanent dentition into a class 1 molar relationship using the primate space early shift and the late mechanism using the leeway space. And of course, the other deviation looking at the mesial step ending with a class 3 and the distal step ending into a class 2 molar relationship. Now, the dimensional changes in the dental arches, we already talked about that, but we're going to talk about the during the mixed dentition. What happens is that the intercanine width during the primary dentition, as we said, it increased about 1 to 2 millimeters in the mandible and up to 4 millimeters in the maxilla. And that's it. Sometimes this will stay still, sometimes it will decrease gradually, leading to some crowding. So as you can see, the distance from the mesial surface of the 6 all the way to the mesial surface of the 6 on the other side, this circumference usually has minimal changes with the growth. What happens is that the length of the end where we have the 6 and 7 and 8 erupting, usually it will get longer to accommodate the new teeth. Otherwise, the dimensions here, the length of the arch, the intercanine width are usually, the changes are minimal. So the only significant change in the mandibular intercanine width occurs during eruption of the permanent incisors. So that's the early mixed dentition, when the primary canines are shifted distally into the primate spaces. And that's it. Usually the intercanine width after that has minimal changes. In terms of the measurements between the lingual cusps of the second deciduous molars or premolars, and that is the width of the premolar area, again, it will increase slightly in the mixed dentition, and then after that, it will be established. Minimal changes will occur. The circumference, as we said, the arch length from that includes the premolars, the canines, and the incisors will have minimal changes. in the maxilla. There are little changes with age. In the mandible, there will be decrease of about 4 millimeters, and the reason why is because we have more leeway space in the mandible than in the maxilla. And leeway space means that the 6 will have a shift, mesial shift, so that will reduce the arch circumference, that is where the central canines and premolars are actually occupying the circumference. So this will reduce in the mandible of about 4 millimeters. Now, regarding the third molar, with regards to the third molar, usually it, as we said, if it doesn't develop and shows on the radiograph by the age of 15, then it is considered congenitally missing. And usually we have about 34% of the population, they have no wisdoms, congenitally missing, they will have congenitally missing third molars. But if it's there, usually it will develop and it will erupt around 17 to 21 years of age. There is lots of variability related to this tooth, and we might have delayed eruption as well. Now what happens is that as the third molars erupts, there is a theory that it will push the rest of the teeth and it will cause mesial drift of the rest of the teeth. And its eruption, rather than its impaction, will have some effect on the mandibular arch and cause crowding. But actually there is no evidence, as the crowding in the lower arch is multifactorial. And just prophylactic extraction of third molars is not recommended. According to the National Institute of Health and Care Excellence, which is the NICE guidelines, they recommend no extraction of the third molars, just to prevent the crowding in the lower, in the mandible. Okay, so this is not recommended. This should be discontinued. The only recommendation to extract the third molar is a third molar with a problem that is causing pathology, carries risk of root resorption of adjacent teeth, or carries risk of, for example, increased risk of caries, or is causing multiple inflammation, recurrent inflammations around its area of eruption. This is the only time when you are supposed to extract the wisdoms. Otherwise, according to NICE guidelines, extraction of wisdoms just to prevent crowding in the mandible or crowding in the arches in general is not recommended. Now, we're going to talk about what we call crowding, and crowding where we have lack of space within the arch to accommodate all permanent teeth. And there are 3 classifications of crowding. We have the primary crowding, where we have difference between the mesodistal width of the permanent teeth and the arch length, and we call this tooth size arch length discrepancy. Okay, so sometimes we have big teeth plus minus small arch, so we will end up with crowding, and this is usually genetically determined, and it is called primary crowding. It is called primary crowding. Other causes of crowding is related to local factors or soft tissue factors related to the function of the tongue, the muscles, the lips, and this will cause crowding related to environmental factors, and we call this secondary crowding. For example, if we have an early extraction of second primary molar, this early extraction will lead to mesial shift of the first permanent molar and loss of space, and we will have potential crowding and impaction of the second premolar. So we call this secondary crowding. Now the third type of crowding is crowding related to the lower labial segment, and we call this late lower incisors crowding. Late lower incisors crowding, and usually it happens during adolescence and post-adolescence stage. Why do we have this type of crowding? This type of crowding is classified as tertiary crowding. Well, this type of crowding is multifactorial. There are lots of theories related to late lower incisor crowding, but it's part of normal development of the occlusion. So we would tell the patient that between 18 and 22 years of age, it is expected to have some mild crowding in the lower labial segment. This is considered normal. Late lower incisor crowding was related to mandibular growth rotations, anterior components of the occlusal forces. So occlusal forces has a vertical component and has a horizontal component that directs teeth mesially. So it can cause shift of teeth. Also, it is related to physiologic mesial drift, soft tissue maturation, degenerative periodontal changes allowing teeth to drift under light pressure. So if you have any compromised periodontal conditions, this will lead to drifting of teeth. Also, change in the diet and lack of interproximal wear can lead, in theory, of course, can lead to late lower incisor crowding, because now the modern diet is soft, while in the past we had first diet that needs lots of chewing. So lots of chewing means more vertical movement of teeth, and this will lead to wear and attrition of the contact points. So this is what we call interproximal wear. So because of the modern diet, we don't have interproximal wear anymore, so we have instead crowding. This is the theory. Also, this was related to tooth size and shape, tooth loss and drifting leading to changes in occlusal function. And of course, finally, they tried to relate the mandibular third molar's presence and position to the late lower incisor crowding. So it's important to know that this phenomenon, the late lower incisor crowding, is multifactorial. There is no very clear cause to this problem. And we said that 34% of the population, they have congenitally missing third molars. Yet, this part of the population, they still experience late lower incisor crowding. So it seems that the third wisdoms are only, let's say, it's a coincidence that during the development of the late lower incisor crowding, we will at the same time or at the same stage we have eruption of third molars. This is a coincidence, and this is why NICE guidelines do not recommend extraction of third wisdoms just to prevent late lower incisor crowding. So it's important for us to know. Finally, the Andrews 6 keys to normal occlusion in the adult dentition and the permanent dentition. We talked about this in our first lecture, and now you know how we go from the early dental development, birth, after birth, all the way to this normal occlusion. Okay, so we have all different physiological stages. You need to know what to consider normal and what's abnormal, and review the normal eruption of the occlusion for your patients. So just to remind you, the molar relationship should be class 1 molar relationship, where the mesobuccal cusp of the upper should occlude in the mesobuccal groove of the lower, first permanent molar. The crown angulation should be a little bit of mesial tip. The crown inclination, usually the anterior teeth are buccally inclined, while the posterior teeth are lingually inclined. Or we also call this torque. There should be lack of rotation, there should be lack of spaces, and the occlusal plane should be minimal. We should have minimal curve of SPE or even flat occlusal plane. Okay, so this is covering the occlusal development with its different stages. Thank you for listening.